Edmonton in beginning of June, and so it seemed very appropriate to, as the same issues apply to us, to have the same talk now, although updated. So I am pleased to present Lawrence Cheng. So I'll hand it over to you, Lawrence, and thank you.
Great. Thank you very much, Julian. Good morning, everyone. It's a pleasure and it's an honor to be presenting once again to the emergency department community and all of us who truly want to improve the care to give our patients. Emergency department overcrowding, it's a big issue. It's a big topic. There's lots of things to talk about, and I hope to share with you some key points that I've learned as the physician operations leader at St. Paul's over the past 5 years, where we were trying to make some big changes. So yes, I would like to leave some time for questions at the end, because there's lots of things we need to talk and discuss. Okay, so most of you remember this news item back in March of this year, and so overcrowding is alive and well in Canada, and we'll just go through some of the historical things, but it's been a long time that we've had this emergency department overcrowding. This whole Tim Hortons turned ER, it's both a sad sign of times where this is where things still are at in terms of our capacity in EDs, but it also shows our resourcefulness in terms of doing what we need to do to care for our patients. So it's got both sides of that story. Okay, so I'm going to discuss ED overcrowding. What is it? Have we really defined it at this point? What are the causes? Do we understand it? Can we measure it? How do we measure it? What are the consequences of overcrowding? What does the literature say? What can be done? What has been successful? And some thoughts about why we still have overcrowding. Okay, so I think in terms of definitions, I think we're fairly confident that we know what it is. I think all of us clinicians, we know when we're having problems in the department. The definition from CAPE and NINA is that ED overcrowding occurs when the demand for emergency services exceeds the ability of an emergency department to provide quality care within appropriate timeframes. So those definitions I think we understand. But my question always has been, why is it that we still have this problem? The first reports of emergency department overcrowding in the literature, at least in Canada, is, Garth Dickinson had this editorial in February 1st, 1989. That's 20 years. We made, Time magazine cover, emergency department crisis, back in 1990. And I think what we really understand now is that ED crowding is a local manifestation of a systemic disease. So we'll talk about some of the issues of why, even after 20 years, we're still talking about it, and doesn't look like we've solved this problem. Okay, so here's a little quote from Dr. Dickinson. So this is back in 1989. It is important to note that the overcrowding problem was not solved by increasing the number of staff or the physical capacity of the ED. The overcrowded emergency department was really an inpatient facility operating inefficiently and beyond the limits of its resources. We knew this in '89, and why are we still in the same condition? Okay, so just a kind of overview in Canada. This is the Canadian Agency of Drugs and Technology Health Report, which is an arm of the federal government. In 2006, it did a good study and survey, and 62% of ED directors reported a major or severe problem. It seemed to happen more likely in EDs that were of larger size, greater than 50,000 visits per year, population base of over 150,000, university teaching hospitals, trauma centers, and departments that had greater than 30 or more treatment spaces. So again, we're in 2011, and I don't think things are much different. So do we really understand the causes of ED overcrowding? Of course, it's multifactorial and complex, but I think there's pretty good consensus both in Canada, the US, and the rest of the world, is the principal cause is hospital overcrowding. And that, of course, is the consequence of insufficient acute care beds, staffing issues, and then all the community care resources and a lack of integration. So once again, really, as many people have said, the emergency department overcrowding situation is a symptom. We are like the canary in the coal mine of a system that doesn't work. The second cause is compromised flow to the ED. So it isn't just hospital and system things, there's definitely things we need to do better in the ED. One of the other factors is that in most provinces there has been a 30 to 40% reduction in hospital bed capacity over the past decade. So our buffers of inpatient capacity have definitely gone down. Okay, so how do we begin to think about this problem? Asplin promoted this sort of model a number of years ago, and it's still a very useful model. And it just breaks it down into a simple way of thinking, input. So this is patients coming in, either walk-ins or ambulances, referrals. Then you have your throughput section, which is, of course, everything from triage right through until our discharge or disposition decision, and then the output of where the patient actually goes. So that simple model is useful as a framework. Now, again, back to the CADTH report in 2006, ED directors were surveyed, and again, the lack of admitting beds was the top 5 reasons in terms of overcrowding. The lack of acute care beds was number 2, and then ED length of stay for admitted patients was number 3. Increased complexity of acuity was also a factor, and then occupancy rates of ED stretchers, which was largely a consequence of patients not moving out of the ED. So it's pretty clear that the main cause for overcrowding is actually the inpatient bed capacity, and it's not the walk-in wounded or lower level CTAS patients. Again, a few other things from the seminal report by the Institute of Medicine, Hospital-Based Emergency Care at a Breaking Point. They quoted that in 2006, the General Accounting Offices concluded again that the inability to transfer admitted patients to inpatient beds are a leading cause of crowding. And Michael Scholl's report here again emphasizes the point that crowding is not caused by non-urgent cases. Low complexity patients are associated with a negligible increase in ED length of stay. And this, of course, was a big myth for a long time, that it was the lower CTAS patients that were actually causing problems with crowding. I think we should be just done with that concept and realize the fact that it's the admitted patients who are boarding in their EDs that cause the problem. Okay, next slide. Sorry, there's a bit of a hold up here. Julian, I can't get this slide to advance.
Okay, we're just going to work on that. There we go.
Has it changed? No, it's
yeah, it should be on slide 13 now. 10 measures for ED overcrowding.
Yeah, okay, my computer is somewhat slow. Okay, I'll just start talking, hopefully it'll catch up. So yeah, so one of the fundamental difficulties is our inability to measure overcrowding or to come up with a universal definition that we can agree upon. You know, the absence of a defined and agreed upon set of measures, it's made it difficult for us to research it and to talk about, you know, standard metrics. There have been some attempts to do that, as you can see from these sort of complicated equations, but I don't think we've quite figured out the mathematics of how to define this. We've got some simple measures, but it may not take into account all the variability. And that's that bottom line. You cannot measure what you cannot manage what you cannot measure. I still can't see it on my screen, so I don't know whether you guys should maybe just take control of the slides.
Okay, we'll take control then, Lawrence.
Okay.
Like to go to the next one?
Okay, so we're on slide 13, 10 measures of ED overcrowding. So again, this was a study that looked from the Canadian experts at how can we actually measure this? Are there some measures that we can agree upon? The top one was a percentage of ED occupied by inpatients, was felt to be one of the top measures we could use. Total ED patients in the ED at a given time, total time in ED, percentage of time ED at or above capacity, time from bed request to bed assignment, time from triage to EP, MD satisfaction, time from bed ready to transfer to ward, and some sort of number in terms of staffing levels. So again, we're not there yet. We're still coming to consensus in terms of what would be the measures, but we're getting there. So these are some of the measures that Canadian experts have agreed upon. Slide 14. So there's a growing body of evidence that suggests that ED overcrowding is truly associated with both worse, objective clinical endpoints such as mortality and morbidity, as well as clinically important processes of care, time to treatment. So worst in terms of mortality, morbidity, increased risks in terms of medical errors, patient safety, patient dignity, which we don't talk so much about, compromised infection control, and of course, from the administrative side, prolonged ED length of stay, increased walkouts, left without being seen, ambulance diversions, decreased patient and staff satisfaction. So there's a huge amount of consequences, and the literature is showing that clearly, it's not just anecdotes. There's evidence to suggest that. So I'm going to just go over some of these on slide 19 now. So increased mortality, it's fairly clear that prolonged ED length of stays are going to infect mortality here. So observational studies have indicated that ED crowding may be associated with higher mortality rates, not even just the initial visit, but up to 30 days. This was a report in Academic Emergency Medicine. Another report showed that the hazard ratios were increased for mortality, again, not even just at the initial visit, but subsequent days, at day 2, 7, and 30, when we had the greatest ED and hospital occupancy rates or overcrowding. Slide 20. And of course, in the lay press, we still have stories that abound. Here was a report back in Winnipeg not that long ago. So the literature and the lay press, again, still support that this is a significant problem, and it's not just anecdotes. There's a lot of literature that supports this. Okay, slide 22. There's a study from the critical care literature that showed that in-hospital mortality was higher, 17.4% versus 12.9% in patients that were held in the ED for greater than 6 hours, as compared to patients moved to ICU in less than 6 hours. Of course, we know this to be true. These are our sickest, most complicated patients, and if they're not in the right place in an ICU bed and they're in our EDs, or overcrowded EDs, it's going to affect mortality. And the study shows a definite increase in mortality. Another study also showed that absolute mortality risk of 4.5% increase for extended boarding of ICU patients. Again, I think for many of our places, these patients, the high risk, the high acuity patients who are staying in our EDs for longer than they need to are suffering much worse clinical outcomes. In terms of other clinical consequences, overcrowding is definitely causing delays in antibiotic administration, delays in thrombolytics with measurable worse outcomes, and certainly delays in analgesic administrations affecting our quality of care of our patients. Slide 24. There was a recent study by Rick Ma that was in CGEM, and we also have to think about this side from the patient's perspective, and there's a significant amount of effects in terms of loss of dignity. and he cataloged a number of stories which are quite moving. We really need to think about this overcrowding problem as also a threat to patient dignity. Being ignored or insufficiently acknowledged, being seen but only as a member of a group, not seen individually, having one's personal space being transgressed involuntarily or hopefully not, humiliation. Dignity really is the cornerstone of our humanity, and as doctors and providers, we really do have a moral obligation to our patients to preserve and promote it. And so in a sense, ED overcrowding can be seen as a humanitarian crisis as well that we need to fight for. Slide 25. Of course, ED is now also being considered as a hot zone in terms of problems infection control. There's definitely a growing body of evidence in the literature showing the links between overcrowding with MRSA transmission. And of course, we fully understand what happened with SARS, where there was a single unrecognized patient in a crowded ED and created an epicenter of an outbreak out in Toronto. So again, just cataloging the real consequences of ED overcrowding. And on slide 26 now, in terms of what we talk about surge capacity and disaster response, overcrowded EDs have no buffer to increase our capacity and respond to these type of events. I mean, how can we talk about this type of response when we can barely handle our normal Monday peak volumes? Slide 27. So the understanding is that ED overcrowding is a system problem. It needs system solutions, but we still need to fix our own backyard. And there's enough evidence out there that significant gains can be made by applying operational management principles, learning from other departments, learning from other industries. But still, in terms of the academic literature, there's not that much that can guide us. Okay, going to go through some important concepts in terms of ED overcrowding and how we can begin to tackle this. So how can we gain 81,000 hours of stretcher capacity, which is a tremendous amount of additional capacity, without actually necessarily spending any money? So if you look at the before section and ED length of time, say ED length of stay of 2.5 hours, times our annual census, this was a number of years ago at St. Paul, 63,000. That's 158,000 stretcher hours. If we reduced our ED length of stay on average by half an hour, from 2.5 to 2 hours, in that 1 year, we would go down by 126,000 hours, and we would gain 32,000 hours of stretcher capacity if we reduced our ED length of stay by half an hour. Going to the middle column, if we decreased our waiting time for consultants from 5 hours to 2 hours, so reducing consult waits by 3 hours, we would gain 33,000 hours. And 11,000 is the number of consults or admissions we would have in an average year. In the last column, waiting for a bed, so patients being, the decision has been made to admit the patient and they're waiting to go upstairs. And this was a number of years ago, our wait time was about 11 hours. If you reduced your wait time for an inpatient bed from 11 hours to 2 hours, you could gain 81,000 hours of stretcher capacity. So the point here is that if we can increase our throughput, decrease our lengths of stay and delays, we can actually gain significant amount of actual real stretcher capacity in which we can see our patients in beds instead of in hallways and chairs. Slide 29. Here's just another illustration on a graph. This shows you our typical ED volume curves. The top curve shows an ED that has a less efficient department, so an average throughput or ED length of stay of 4 hours. And then the light gray curve below it is an ED who's got a length of stay, average length of stay of 3 hours. And you can see on the vertical axis, which is census, that for every hour of the day as it starts to ramp up, the ED that's less efficient is going to have a greater census number than the more efficient department. So again, a department that's less efficient will feel significantly more overcrowded because there'll be more patients in the department at a given point in time. This basically just underlies the point that an efficient department moves people through and is a main strategy against overcrowding. Okay, slide 30. So on the input side of the equation, of course, these have to be addressed, but they're often outside the span of control of the ED management. But anything that sort of reduces avoidable ED and hospital admissions and alternate sources of care, community care, better integration is going to help decrease our inputs. And these are things that, of course, have to be worked on. The part that we do have span over control, slide 31, is our throughput. And this is where many of us have to work. I'm just going to kind of go through concepts of really where we should be in terms of ED department. Front piece, front-end tasks should be collapsed as much as possible because the goal, of course, is to get the patient to the provider. Everything before that is really, you know, from a patient's perspective, not really essential. So triage and registration should be collapsed as much into a single process as much as possible. Best practice is going to be less than 2 minutes for express registration plus triage. Again, ideally as a single process. Patients should go direct to stretcher whenever it's possible and have the registration done at the bedside. We need to collapse the assessments together. Can MDs and RNs do the assessment together instead of two serial processes? If you have no stretchers, we need to be thinking about things like rapid assessment zones where patients can be seen quickly and they don't dwell in beds, but they get assessed, initial investigation started, and they move out to a chair if necessary. Or even the concept of what Grant Innes talked about was a waiting room triage team or SWAT team, where a team actually went out into the waiting room to see and assess patients quickly in times of surges. Looking at the improving reliability section, seeing if we can use, where possible, computer physician order entry systems where we eliminate all the delays of transcription of orders, using order systems where we integrate pathways, algorithms, and order sets so we reduce all those inefficiencies. Next slide. The next piece is to really be able to manage our departments in real time. So do we have tracking boards that give us our functioning capacity? What's our X-ray delays, our capacity? What's our lab delays? Where are our core processes being held up? How can we respond quickly and tactically? Having set benchmarks for all of our ancillary tests, lab tests less than 1 hour turnaround time, radiology defining CT turnaround times, ultrasound times, ECG times, having these defined and measured in real time as much as possible. This includes defining consult decision times. At St. Paul's, we have a 2-hour benchmark. Having a streamlined discharge process and moving patients out of beds as soon as they don't need them. And then managing the whole transmissions to admissions, which is a whole big piece, but have we defined specific time benchmarks, and have we looked at expedited admission policies, emerge docs writing admit hold orders for certain patients, and basically streamline the entire admission process. So this is basically a vision for operational excellence at this point. And this is within our span of control. And this is where our work is. Okay, slide 33 is a demand capacity management slide. And again, it's looking at that concept, have we optimally matched our resources to meet the demands by hour of day? And so you really have to understand by each hour of the day what your inputs are, what your volumes arriving at triage, and do you have sufficient triage capacity? sorry, do you have sufficient physician capacity, and have we matched these as best as we can? Slide 34. Sorry, after you've matched your capacity as much to your demand, you're always going to have surges. And so you need to have a surge capacity plan. This is extracted from our St. Paul's plan, where we define 3 levels of operations: green, yellow, and red. And you can see on the top part of the table, we've got the different dimensions. We have, number of patients that are waiting at triage, number of patients waiting for a bed, number of patients who are waiting for physicians that have exceeded C-test times, etc. And we've tried to define the operation levels, and once they go into a yellow zone or red zone, there's predefined thresholds and there's predefined actions that get enacted. So I think this is a crucial piece for all of our operations, is that we need to have a surge capacity plan. How do we respond when we are increasing levels of demand and it's outstripping our resources? Next slide. Many places have this type of thing, tracking boards, and I think this is absolutely crucial. I mean, how can we manage our complex environments if we don't know what's happening in them in real time? It's like trying to drive a car or operate machinery without any instruments. So I think every department needs to move to some sort of tracking board where we can track how long patients have been there, how long someone's waited for a CT, how long x-rays been delayed for, have all the lab tests come back, et cetera, et cetera. We are a minute-to-minute operation, and there's no way we can manage our department efficiently without these type of tools. Next slide. The next step, even beyond the patient tracking board, is a dashboard which essentially aggregates operations. So for example, this type of dashboard would be available to all the users of the ED and the managers, and it would show you, for example, what is lab processes being delayed, as a whole, not just for one patient, but for the whole department. And if it's going into a red zone in terms of operations, then it needs to trigger some response. The unit coordinator calls the lab, finds out what the delay is there a machine problem, is it a collection problem, same thing for CT, same thing for physician delays. So it aggregates these type of operations and allows management to respond better. Again, I think the real-time dashboards are still at an infancy. I think in the States they're far more advanced in terms of this. At St. Paul's we've been in development of a real-time dashboard, but that's definitely where we need to go. Okay, next slide. So looking at the output part, given the fact that we understand that really is the admissions patients, the admitted patients who are boarding in our EDs, this is for most of us the most important piece of work. And I will say that there's, this work has to be done in conjunction with the hospital with significant senior leader support. This is not something you can just go and move the medicine units or the inpatient units without significant support. There is a way to do this. I've taken this model from the Institute of Healthcare Improvement. The buckets of which the work needs to be done, first is the demand capacity piece, is being able to understand the number of patients being admitted to a service by day of week and even by hour of day. Can we predict what our demand is going to be? Can we create early warning and response systems in terms of admissions and surges in admissions? Can we have sort of real-time measures and a bed ahead system where we signal the admitting departments way before they actually get transferred? We often know when a patient needs to be admitted, even within 10 minutes of seeing the patient. Can we give an early warning to the medicine department that there's going to be a potential admission? The next piece is looking at the recognizing bed availability. And for a lot of places, we're moving to these bed dashboards that really can keep track of whether a patient's being discharged upstairs, whether a bed's being clean or dirty, etc. You need to have dedicated bed access people. And again, that's a big piece of work, but absolutely crucial. The next piece in optimizing admissions is executing the transfer. And ideally, it's a pull system from the unit. They've got a bed ready, and they're pulling the patient upstairs. It's talking about streamlining and having dedicated transporters, looking at systems such as admission teams where a team comes down from the unit to the ED and facilitates the transfer. So again, the execution of the actual transfer is absolutely a crucial piece. And then the last piece, which is really in the purview and span of control of the inpatient units, is their management of their beds, efficient use of their beds. So that's case management, discharge planning, housekeeping coordination. So for a lot of us, in terms of ED overcrowding, it's going to be optimizing the admissions piece and really working in collaboration with our inpatient units to see if we can improve the flow through. Okay, next slide. The other concept that we need to really explore in terms of ED overcrowding, and again, the Institute of Medicine highlighted the use of buffer units, and that's the concept of the DTU, or observation units. But there's other units as well, like the MAU, which is a medical assessment unit, high dependency unit, psychiatric assessment units. The concept of buffer units is that you want to protect the ED core stretchers only for ED patients who need to be in there. Every unit has a buffer unit. So medicine has a buffer unit between ED and medicine, and that's a medical assessment unit. The ICU may have a buffer unit with the HDU. Psychiatric inpatient unit may have the psychiatric assessment unit as a buffer. And in a sense, for the ED, our waiting rooms are a buffer. So again, I think these are very powerful concepts. I think a lot of places are beginning to move to an observation unit DTU. At St. Paul's, we've had one for now, I think, 6 or 7 years. And I think we've had great success with having a unit where we can put patients in for up to 24 hours and have a third option instead of admitting the patient or discharging them potentially too early. Okay, next slide. Okay, so kind of looking at this complex issue and asking the question why, even after 20 years of clearly understanding what the problem is, why we haven't necessarily solved it. One of the thoughts now is to really look at the ED as understanding as a complex system. And, you know, if you think about it, we are really the only system that has to cope with any and every eventuality that can befall a person 24 hours a day, 7 days a week, 365 days in a year. And in a sense, we live at this, what they call sort of the edge of chaos. When you talk about complex system theory, we have to handle a multitude of different problems simultaneously, none of which can be predicted in advance. So it's a tall order to have a functioning system, and what we're trying to do is build a resilient system. There is a number of literature that's starting to use complex system theory to understand and also to better manage how we do run our EDs. So I'll talk a little bit about that as a new concept. Next slide. What we're learning from the study of complex systems is that these type of systems are almost too big and complicated for anyone to truly understand what's happening at a given time. This means subsequently that over-control and over-design will not work. This means management style of prescribing every procedure in a detailed format may not work because we don't really understand the system, we don't understand the consequences. And this may also mean why traditional kind of continuous quality improvement approaches are not able to solve these complex system problems. Next slide. So some of the thoughts coming from the complex systems theory is as follows. Number one is avoid over-design. I think we've all gone through this where we try to prescribe all sorts of procedures for every eventuality in the ED, and you end up with this massive procedure manual which no one even looks at, and there's so many conditions which it doesn't apply that it's not relevant. So can we use a few simple rules that are applied uniformly that lead to well-functioning systems? This sort of presupposes that your individual actors, like your providers, your doctors, your nurses, your housekeepers, understand these rules and they can act and make the best decisions. The other concept that's coming out of this is follow the 85-15% of the rule. We don't need to change 100% of everything. In fact, if we find the right 15% that we can adjust and lever, the rest of the system will self-organize in the desired direction. So in a sense, that's good. We don't have to find all 100%, it's finding the right 15%. The other concept which I think is really important is establishing minimum specifications. So again, in a complex system, we can't prescribe everything, but let's define the minimum specifications, and then we let the actors, our providers, self-organize themselves to achieve these results. And really important concept, it's really the people within your complex system which allows you to have a resilient system. So the skill, and intelligence, and innovation. We have to invest in training our people, maintaining healthy systems that maintain healthy people and networks. And the last concept, which is really important in complex systems, is you need to have data, and they have to be shared in a transparent and meaningful way to everyone on the team. Okay, next slide. Again, a concept that people are really talking about in terms of managing ED overcrowding is the concept of resilience. And resilience is defined as the capability of a strained body to recover its size and shape after deformation. So a rubber band is classic sort of example of resilience, but it also has a limit. A system has a limit. Rubber band has tremendous elastic capabilities, but only up to a certain point, at which point it will actually break. And the EDs are the same. We have tremendous amount of elastic capability, but we do have a breaking point. And it's important for us to understand where the bounds of operations are for us. Okay, next slide. So what's the difference between sort of a resilient response and what they call a threat rigidity response? There's two ways a system can respond to stresses. In the threat rigidity response, we kind of narrow our information processing. We sort of say, okay, we can't handle all this information or the load or the stress, so we're just going to ignore it or ignore parts of it. We try to centralize and formalize control. We try to conserve resources and ration resources. And in fact, what happens, we decrease our ability to cope with these sort of challenges. In a resilient response, we are able to sustain competent performance by increasing our ability to process information. In fact, what happens in resilient response is that there's a loosening of control and allowing individual providers much more autonomy. And the concept of having and utilizing slack resources is really important. And unfortunately, this is where we're often faced, is we don't have any slack resources, which impairs our ability to be resilient. So resilience in the ED is our ability to sustain competent performance without a decrease in the quality or timeliness of care. And I think that's what our goal is to become a resilient system. Okay, so next slide, slide 45. Again, this is sort of a new concept, but we need to sort of explore this further. A lot of resilience is going to come from investing in training and retraining of teams and working with teams. And what some of the teamwork literature says is that there needs to be consistent schedule for training and also retraining, because teamwork does decay over time. We have to really continue to always improve the capabilities of our providers, of our staffs, to learn quickly, improvise, adapt, and bounce back. And we have to always embed knowledge in terms of the rules and practices and into a workflow. Okay, next slide. We're going into the summaries here. So lessons learned. If we're going to solve overcrowding, it requires system-wide solutions and accountability. There's some examples of these larger system incentives. For example, the P4P incentive scheme that started at Vancouver Coastal and has spread to many other regions. And that has shown some significant benefits in terms of aligning incentives and aligning the hospital to make investments that will help with flow-through. Next slide. The lessons that we're learning is that change can be accomplished, that we need to use all the tools available that are around from operations management research, from other industries. These include tools such as Lean, Six Sigma, etc. Next slide. Interventions require strong leadership and collaboration, not just within but outside EDs. There's really no other way except strong leadership and collaboration. And lastly, we really need to apply evidence as much as possible in terms of ED operations, and continued research and management and measurement is crucial. Okay, next slide. Why change? Well, I think from an evolutionary perspective, Charles Darwin had something to say about this. It's not the strongest of the species that survive, nor even the most intelligent, but the ones most responsive to change. And I think the ED is where we felt these evolutionary pressures, and we've been forced to change. And oftentimes our counterparts in the inpatient units, they haven't felt the pressures, and so they haven't been forced to change. So we're at the sharp end of the stick in terms of adaptation. Next slide. You know, sometimes when you're doing this kind of work, you feel like your staff are saying, you know, go ahead, make one more change, one more test, or one more PDSA cycle. I mean, a lot of us are getting fatigued in terms of changes and the rapidity of changes. There was a big report, the Institute of Medicine, To Err is Human, which really said that we really have to change, that we can do much better for our patients. Next slide. Okay, so slide 55. So what doesn't work? You know, I think we know that whining doesn't work. The next thing that really doesn't work is trying anything without senior leadership support, especially anything that involves the admission piece. Trying anything without ED staff support. And again, what's being very clear as well is building more ED space or building more ED stretchers without really looking at the actual processes is not going to work. Next slide. Now, what does work? Again, the literature and management literature is starting to catch up and summarize these things. This was a great report from Urgent Matters called Perfecting Patient Flow. There are a number of common themes to all high-performing sites. Number one, leadership comes up again. They have to recognize that ED crowding is a hospital-wide problem, not an ED problem. Number two, you have to have multidisciplinary teams in order to design and implement change. Number three, senior leadership team or executive teams have to publicly support ED crowding strategies in their hospital. Number four, we have to use formal quality improvement tools. Routine and rigorous data collection is essential in terms of this type of work. Number six, initiatives and data must be transparent to everyone. Number seven, an institutional champion for change is needed. And as well, that also means they need dedicated time to support this improvement work. So those are the top 7 themes that we understand now very clearly from over 20 years of dealing with this problem that have to be in place. Next slide. Borrowing from the IHI model, you have to have the will. And in addition to the will, you need the ideas. And there's lots of ideas out there. And then you need the execution. So you need the fundamental of culture, leadership, plus engagement and empowerment. You have to use tools like the model improvement. You have to use Lean, Six Sigma, etc. We have to use project management tools. All those things are required to actually go from actually having the will to do it to having an actual execution and improvement. Next slide. Just a few other concepts which people are talking about, which I think can be very useful for us solving this ED overcrowding problem. Another concept that's coming up is positive deviance, which many of you might have heard about. And this is the concept which arises from the observation that in any community or system, there are certain individuals or groups whose uncommon or deviant behaviors, in a positive sense, or strategies enable them to find better solutions to a problem than their peers while facing similar challenges and constraints and having the same access to same resources. It's finding those people at the tail end of the curve who are managing to function and learning from what they're doing. The positive deviance approach sort of has a number of principles which I think are very, very useful. And again, it focuses on the fact that the people are the experts. You have to have community ownership at all stages, involvement of all stakeholders. It's looking at discovery of existing but uncommon strategies and highlighting those and learning from them. The emphasis is on practice and action. It deals and emphasizes the fact that it's about expanding and creating new networks and exploiting these networks of people and communities. And as well, the community-created monitoring and evaluation, again, the measurement piece really helps facilitate, promote further change. Next slide. Another approach that the NHS is really onto, and they have an entire academy called the Academy for Large-Scale Change, and they're calling that the social movements approach, which is, again, underlying the cultural type of approach. The differences between a traditional project approach and sort of a social movements approach, a project approach, you're kind of looking at centrally led, centrally planned programs. And social movements, you're looking at, again, looking at the actual people, the individual actors releasing energy, and is largely self-directed. Project approach is about motivating people. Social movements, we're looking at moving people from a deeper center. Project approach, people are often saying, well, what's in it for me? What's the positives for me? The social movement saying that we're aligning to a greater purpose, and that may in fact mean there's some personal cost, but we're aligned to a greater purpose. The project approach looks at overcoming resistance and social movements because everyone's bought in to a greater reason. Opposition is necessary. We want to have that opposing force, but we have an underlying principle that we're all aligning to. So social movements is an approach which I think really looks at the cultural aspects of ED overcrowding. Okay, next slide. So what does the literature say in terms of effectiveness of our interventions? It has been very difficult to determine the relative value of these different approaches, and it's really hard to see what the benefits are, but if you do measure them, it does seem to have some moderate to large treatment effect. Efforts to address overcrowding really need to be encouraged because they will have success even though the literature is not clear about it. And we need to have multi-component interventions. Next slide here. So why do we still have overcrowding? And there's a number of reports coming out here, and I think we understand this, is that if we basically have symptomatic remedies, we're only relieving the pressure on emergency room problems. But the real problem is much more complex, and we're not really addressing the root causes, which is system-wide throughput issues. Next slide. So the future. So given the projections of changing demographics, current access to care issues, all these things are going to increase, and they're going to be increasing complexity. And really, ED overcrowding is not going to get better unless we really find the specific root causes and address them. And again, these are system-wide issues. And largely, in this big report, it's access to care across the continuum that has to be made more readily available that's going to have an impact on ED overcrowding. So again, it's a system issue that has to be addressed. So lastly, this is always a great quote from Machiavelli for all of us doing this type of work, is that there's nothing more difficult to carry out nor more doubtful of success, no more dangerous to handle than to initiate a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders in all those who would profit by the new. That's it. Thank you. So we have a few minutes for questions. That's a lot of stuff in a big overview, but I'd like to open up to any questions and comments.
Thank you very much, Lawrence. This is Julian. I just let everybody know that I've unmuted everybody. So if you have a question, you can either raise your hand or just start speaking. We've got just about 5 minutes. So as I said at the beginning of this, we are recording this, and this will be placed on the E2E or Evidence to Excellence website in a couple of weeks. So, but I see a hand from Gary. So Gary, you're up, sir. Gary? I'm not sure, Gary, if we can hear your, if your microphone's on. If maybe you want to just type in your question, I can read it out to the rest of the people. So Gary, I'm sorry, we don't seem to get your any coming in. Sherry, are you able to ask your question then?
Can you hear me okay?
Yeah, we can hear you fine.
Okay. Lawrence, that was great. You know, no matter how many times I listen to you speak, I always pick up new pointers. How is, you had a slide on a surge protocol. So is St. Paul's actively using that slide that you had up there on your internal surge?
Yeah, I think you're referring, Sherry, to the surge capacity plan.
That's it. Yep.
Yeah, the surge capacity plan. Yeah, I would say that we're probably halfway there in terms of the surge capacity plan. We've got our triage surge plan fairly well in place, and I think some of the ancillary responses are there. One of the challenges with our surge capacity plan is we've defined the thresholds, but it's hard to measure because we don't have a real-time dashboard. So that's been a bit of a challenge with the surge capacity plan is, okay, do we know how many lab tests are delayed? You know, I can know that one patient's been delayed, but, you know, has 50% of the lab tests been delayed greater than 1 hour? So some of that has been harder to implement. But I still think if you have a defined plan, at least your staff know what's supposed to happen, even though it's harder to measure objectively where you are.
So do you, sorry to ask one more question, do you find that there actually is a change in response in the department when you have people in the waiting room? Because I find our patients are accumulating, but we are doing business throughout the entire building the same way.
Yeah, so that's where your surge plan needs to come in effect. So if you have a certain number of patients in the waiting room, then things do need to change. I think at St. Paul's we are pretty good at responding. So if there's a certain number of patients in the waiting room, we do start to work differently, and then we try to signal, you know, the other departments to also change and adapt to the surge. So yeah, I think we do. Certainly in the ED at St. Paul's, we change how we work if we've got an increasing surge in the waiting room.
Thanks, Lawrence.
Great, thanks, Sherry. Any other questions? Great. Well, it seems like we're done this morning. So again, Lawrence, thank you very much for taking time out of your conference down in Portland, and we really appreciate you presenting this. And again, as Sherry indicated, I've heard parts of this talk before, and every time I learn something new. So thanks again, Lawrence. This is excellent. And thank you, everybody, for participating. Just for your information, an ad will come out soon, but our next presentation will be on December 2nd, and Grant Innes will talk about accountability measures or accountability in general, and I can guarantee you that will also be a fun talk. So thank you very much, everybody, and thank you again, Lawrence. Take care. Have a great day, everybody.
Great. Thanks, Julian. And I would be happy to answer any questions by email and keep the dialogue going. Great. Thank you very much, everyone.
Thank you, Lawrence. Take care. Bye.
Thank you.